It's like,
Okay, I am just doing the very important work of giving my 13-year-old more screen time on the Xbox so he at least is not streaming during this.
yeah.
Do as I say, not as I do in the
Yeah.
world of parenting.
So
Of
listen,
course,
let's
that's a
get
lot.
started from the top. Welcome back to the Sleep Edit. I am Dr. Craig Canaperi.
And I'm Ariel Greenleaf.
It is my great pleasure to welcome my friend, Dr. Sujay Kansagra, on today. He is a pediatric sleep doctor and neurologist. He attended Duke for medical school, went to UNC for residency and fellowship, and made a triumphant return to Duke afterwards.
Lost
And
some friends during the transition, but yes.
I got to tell you,
Mm.
man, as a lifelong UConn basketball fan, I've got wild beef with Duke.
Yes. I can understand that. Listen, people ask me, who I support, because UNC is where I started as an undergrad. And so the basketball legion still lies there. But
And
for medicine, I'd cheer for Duke.
I still remember UConn losing to Duke in 1990, the first time they made the tournament.
I remember UConn beating Duke in the finals. This was probably 1999, 2000.
Oh.
We were very excited at UNC for your win.
Oh, yeah. And let me tell you, that every time I've won a basketball pool, it's because UNC has won.
Yes.
I just want to talk a little bit about your online presence, because when did you start med school advice? Because that's how you first came on my
Yes.
radar.
This is like the original, back in the day we called it Twitter. I was still a resident, as a child neurology resident. And we were talking earlier, this was really the Wild West of social media. Folks in medicine were just getting their foot in the door and learning to navigate the social media channels. And back then, my goal was just to give just advice, because I grew up having an older sister that went to medicine that helped guide me. And I'm like, a lot of people that don't understand what it takes to consider medicine, what a life in medicine is.
So I started blogging in 2012. And I felt like at that point, it was already too late, right? Because there were already like people out there who've been doing it since the early 2000s. I think Howard Lukes was on from like the 1999 or something. When your pediatric sleep book came out, that's great, guys. You all should buy it. My Child Won't Sleep, a quick guide to the sleep-deprived parent. I've been blogging for 2 or 3 years, and I'm like, man, this guy wrote a book. I better up my game here.
Yeah, who is this guy? Yeah, I mean, that book, it's funny because I was doing a lot of the research behind it when I was a new father. And I was also reading all the books that are out there just to get some background information. What is Weisbluth saying? What is Ferber saying? We knew the techniques, but what do you have in these 400 pages? And part of me, when I came to the techniques, I was streaming at the book, just tell me the technique. I already knew the technique. I'm like, where is it? These are sleep-deprived parents. I'm like, just where's your technique? And that was the impetus behind the book. Just give it to them straight, give them a step-by-step approach. And it's probably too slimmed down because, unfortunately, I glossed over a lot of the other issues like parasomnias and restless leg and sleep apnea. It's just behavioral insomnia approaches, cognitive behavioral therapy approaches for older kids, delayed circadian rhythm stuff for older children as well. Just the core things that you can modify without needing a physician sometimes.
I think that's really valuable in what I do. Parents are there's so much information and they just need an answer and they don't want to sift through a million different things. And I will say those books are great now for me because I dig through them and I look for research and all of that. But when I was a tired new mom, it was like, just tell me what to do, like you said. And ultimately, I hired a sleep consultant because I just could not navigate my way out of it. So
yeah, I hear you. It's tough. There's a lot of information, and people don't know who to trust. Everybody can come across with a beautiful marketing presence and be like, "Oh yeah, you should trust me because look at my amazing graphics." But who can you truly trust when it comes to just vetted science-based folks? Because we love using the science terms out there on social media when it comes to sleep. But who is truly vetting what those terms mean and whether they apply to that particular situation? So yeah, that's why I enjoy the social media world. It's nice to be able to share and hopefully people trust us, like folks that are dedicated their lives to helping children with sleep.
yeah.
Well, Sujay, you're very modest, but you've amassed a huge following, and it's because your content is great. It's very approachable. It's funny. What do you think that you've done that has really resonated with parents?
I think part of it was attention spans are very short on social media. And TikTok actually puts in your face. It tells you like how long people are logged in every second of time. And by 5 seconds, the majority of watchers are gone. They're gone. And so I'll tell you one thing I've learned is you have to have that entertainment portion. Otherwise, people are just not sticking around. And I have no problem embarrassing myself. I kind of joke, academicians are like, oh, you're on social media? That's great. What about all the manuscripts you should be writing? And I'm at this stage in my career where thankfully, I just don't care. Not in a bad way. I'm already full professor. I'm happy to write more manuscripts, but I feel like I can have the most impact on the most people by sharing information on social media. And I tell my academician friends, like, why aren't you on here? Like, if a video that I post, I can get 10,000, 20,000 people to watch it. 5 people are reading the articles that I write in journal.
Right.
Like 2 of them
Yeah.
are the reviewers. So that's it. So entertainment, I think, is important. So getting back to your question. And I think just getting the core of the issues that are on people's minds. Like, the simple topics where they hear lots of different things. Melatonin. Is sleep training harmful? What do we do about naps and how do we nap? And I've also tried to appeal to a broader just sleep audience, not just pediatric sleep, but just sleep in general, and helping adults understand that they need to sleep and the impact that sleep deprivation has on them. So topics that have widespread appeal and then making a fool of myself. I think that's the combination.
Are there any sort of videos you've made that you've been absolutely shocked at how much traction they got?
Yes, it's around the sleep, like the deep sleep science video. So I made one about time zones and how there's this amazing research study that shows that where you live within your own time zone affects how much sleep you get. And that ends up having associative effects on your well-being, like risk for obesity, your productivity. That was like my first video that blew up across platforms, like 1 million views on, like 3 million on Instagram. People really crave the science, and they were asking very nuanced, very savvy questions like, oh, did they control for this? What do you think about this population? And so people out there really understand the science more than we oftentimes give them credit for. And they want it filtered in a way that's, I think, approachable and not in the manuscript form that takes an hour to read. So I was pleasantly surprised. And funny enough, the authors actually of that study found out and they reached out on Twitter. Thanks so much for that exposure. And I'm like, hey, by the way, my viewers have some questions for you. We created a video together in response to the questions that the audience had, which I think is like the most beautiful way of using social media, bringing people together, answering questions.
You mean it's not shouting at strangers?
No, that too. That's totally valuable and valid. Yes, but no, there are other ways of using social media.
Yeah. I think I remember I don't remember what it was, but I remember the first time I got a really mean comment somewhere. I'm taken aback, right? Because I don't think you go through your life, you try to be a courteous person, and there's certain standards of socialization that get lost when people are commenting anonymously. And one of my friends who said a more mature social media presence, she's just a measure of your power. That if somebody's making someone angry in some ways, like just ignore them. But I'm sure you probably developed a thick skin just putting yourself out there like that.
Yeah, absolutely. And I know which posts are going to generate controversy and I brace myself for it. And then I try to be friendly as much as possible because I know at the receiving end, even if somebody that's trolling me, for me to then engage in a ill-spirited way, it will leave a mark on them too, even though they're going to keep yelling back and forth. Put that strain on anybody because then it affects people's sleep and their well-being. And everyone should sleep, no matter how ill-spirited you are to me on social media. And I'm not going to throw that back at you. Even like the one video that actually made me popular on Instagram was one where I did a clap back to somebody that was trolling me and was like, oh, this doctor doesn't know what they're talking about. They oppose sleep training. And then I made this video that's actually, no, I do know about pediatric sleep research because I've published a lot of it. And then I did like a scroll of all my papers. I am the researcher was my quote. I was being like, that's not me usually being like arrogant and cocky. I was trying to actually be a little bit funny. People just ate that up and they loved it. And they're like, what did that lady say when she saw it? And I'm like, I never actually shared that with her. I actually engaged her kindly on Facebook and was like, this is the data behind sleep training. And she shot back a couple of things about, well, we won't mention which group she was with, but ones that are oftentimes against sleep training, which I know you both likely had. Yeah. So at the end of the day, I don't engage, even if I've made an amazing piece of video content that I would love to just show them. I'm not going to do that. Yeah.
I think you should have a masterclass on how to make those videos, man, because they are pretty amazing. And look, as someone
kind
with
of you.
a weirdo background, I'm like, I just don't know how he edits these. They're so good.
That's too kind. I've just become very savvy with all the tools within Instagram. And now CapCut is my newest favorite video editing tool.
I just don't know how you make all the content.
That's the other thing. The funny thing is there are some pieces that I literally, I'm like, I've spent 2 or 3 hours making this video and editing it and et cetera. And then I'll make one while I have a random thought and I'll pull up my phone and just say it. And those videos end up doing much better.
So listen, since I'm not really a neurologist, I train as a pulmonologist and I do sleep medicine, which encompasses a lot of topics. Honestly, I wanted to be a child neurologist, but then I changed course. But we want to talk about some topics that are really, I think, in the neurology end of sleep medicine. And I want to start with parasomnia. And don't know if you maybe just start up by just defining what a parasomnia is.
Sure, yeah. So parasomnias is a group of sleep disorders, and they're typically characterized by abnormal behaviors, sometimes even complex thoughts or emotions that occur at the start or in the middle of sleep or even with arousals from sleep. And the vast majority of parasomnias are fascinating in that we used to think we spent the entirety of our consciousness either in wake, non-REM, or REM sleep. But the majority of parasomnias actually have a mix of elements of two stages at once, oftentimes both in the brain, of like deep sleep and awake, for example, or aspects of REM sleep and wakefulness, which make parasomnia just a fascinating category of sleep disorders.
It's funny how much of sleep medicine is actually where there's a blurring between sleep and wake. Like I think about this all the
Mm.
time in narcolepsy, which is a whole other topic, but narcolepsy, we think of it as sleepiness intruding into wakefulness, and that's very true, but it's also wakefulness intruding into sleep. And it's like where there's that dysregulation of these processes, a lot of problems happen, but a lot of interesting stuff as well.
That's right. We talk about this amazing time at the transition wake to sleep. Weird, interesting things happen. People can have these hip hallucinations, like exploding head syndrome, this phenomenon of feeling like something is exploding inside your head, oftentimes with visual sensation as well. Even what we experience like commonly, like big jerks, that sometimes also have this semi-dreamlike imagery. There's just a lot of weirdness at that transition. And it's fascinating. I think there's a lot of mystery around that time and a lot of fascination with that period.
Yeah. And just for the listeners, the hypno jerks are occurring when you're falling asleep and you have that sensation of falling and you jerk awake.
Yes, I think the evidence is probably pretty weak. And I think the challenge here is that stress is so common that you're bound to see some sort of a link there. But yeah, stress, I've heard, caffeine intake, certainly, sleep deprivation perhaps can worsen hypnic jerks. All the things that are very common in our world, just because, again, hypnic jerks are also common. So I think it's hard to pinpoint.
I feel like that's the good segue into sleep talking or somnoloquy, which is
Mm.
one of those things like, I think in the most recent International Classification of Sleep Disorders, they don't even call it a disorder, which to me is correct. Like sleep talking is more of a phenomenon than anything else.
I'd be curious how often parents, for both of you, how often are parents bringing up sleep talking?
Not often at
Yeah.
all.
It's like on a questionnaire we administer in the office, but I do feel like the idea that it's not a big problem has percolated out there because it doesn't seem to
Yes.
generate a lot of concern.
Same here. It's only time I end up documenting is when I have asked about it. And they're like, oh, yeah, talking about sleep. But it's never an initial concern, which on the spectrum of sleep talking, if it's a problem such that it's happening every single night and we think it's disrupting somebody's sleep, then yes, it's a problem, even though it's quote unquote in the normal variant spectrum. But one, does it rarely come to me as a primary problem. And two, rarely do I feel like it actually ends up disrupting the quality of one's sleep just because it's not pervasive enough throughout the night. And chances are they're, even while they're sleep talking, maybe still getting restorative sleep during that time. We don't really know.
I know that I definitely talked in my sleep, but I wouldn't know. Like I'm told it in the morning, so I'm not awake for it.
My wife tells me I talk not infrequently. And it's usually things that I've been working on the next day or the day before. She's like, yeah, you were working that night too. I'm like, all right, proves that I'm thinking about something.
Yeah, it's hustle culture, man.
Grinding when I sleep. Although I have nightmares of still rounding during residency. I'm not prepared for rounds and rounds are about to start. And I'm like, gosh, I remember during residency, I'd have those dreams. I'm rounding in my sleep at night. When am I not rounding? Sleep
I
is a
feel like
crazy
my
time.
anxiety dreams go back to high school. That was
Yeah.
much more of an anxiety provoking time.
Yes, I think it probably relates to a lot of people. But I think for me, that sense of needing to be prepared and having all the information and then just the angst around taking care of patients. I'm like, you can't make a mistake. Patient care is at risk. I think that was probably hardest for me. And that's probably why it comes back in my dreams.
So Ariel actually said something I wanted to amplify a little bit, which is like, you mentioned night terrors as well as talking.
Mm.
And I think it's important for us to talk about non-REM versus REM-related parasomnias, because it's a really useful part of the taxonomy when we're trying to figure out what's going on with a patient. I don't know if you want to take this, Sujay.
Yeah, happy to. When it comes to the core non-REM parasomnias, we think about confusional arousals, we think about night terrors, we talk about sleepwalking. And that's the majority. Now, there are rare ones, sleep-related eating disorder in older folks, or things like sexsomnia. So there are other rare non-REM parasomnias, but the core are the confusion arousal, night terrors, and sleepwalking. And I like to think of those as the non-REM. And the characteristics of non-REM parasomnias are typically the first third of the night, lack of recollection of the event, usually on the order of seconds to minutes, in rare cases can be longer, and characterized by occurring in relatively young children. We talk about the age range of 3 to 13 is broad, and depending on which parasomnia, some occur more commonly when you're young versus when you're older. Versus REM parasomnias, the hallmark is REM behavior disorder, which in the pediatric population, we rarely see unless it's associated with narcolepsy, because patients with narcolepsy oftentimes do have REM behavior disorder, which is essentially an acting out of your dreams. You don't have the normal muscle atonia, the normal paralysis that you're supposed to have when you dream. It's a very beneficial and safe thing our body does for us, right? It paralyzes us when we're dreaming, so we don't act them out. REM behavior disorder, that paralysis isn't there, or it's partial. You can also have what we call recurrent isolated sleep paralysis. That's also REM parasomnia. Many people have experienced this, particularly during times of sleep deprivation, like during college, where either right when you fall asleep or right as you're waking up, you have persistence of the REM atonia, that paralysis. And so you wake up thinking you're completely paralyzed, and oftentimes associated with a sense of dread and fear, and as if somebody's sitting on your chest, like you can't breathe. We also put that in the REM category. But REM parasomnias usually tend to happen in the latter half of the night, particularly dreaming, recurrent dreaming, or upon awakening with REM behavior, with isolated sleep paralysis.
I want to just actually talk a little bit about the sleep paralysis, because it's one of those things that's absolutely terrifying to someone when it happens, right? And there's also seems to be a certain flavor to the hallucinations that come along with it. So if they're rising out of waking up from sleep, we call them hypnopompic hallucinations. And these don't seem to be culturally determined. And I've heard people commonly say they see glowing eyes in the room, like there are animals there, or they feel like someone's breaking into the room. Sometimes they'll talk about there being an old crone in the room. It's fascinating that these things seem to be hardwired into people.
Yeah, it's frightening when people describe what they're experiencing. I've had sleep paralysis once or twice, and yes, it's really terrifying. You're like sitting there hoping like somebody just touches your arm so you can snap out of this. It's terrifying. But to have that associated with dream imagery, I never had dream imagery with it, but to have both together is absolutely terrifying. We talk about hallucinations like what you're having right as you're transitioning to sleep. And so patients with narcolepsy, oftentimes, for some reason, those involve like aliens or people like in the room. There's a very similar theme there too. People have called 911 because they feel there's intruders in the room. They have these types of hallucinations at the transition to sleep. So I agree. There's probably something hardwired into our psyche that makes us have those thoughts. Yeah.
That doesn't generally happen with the pediatric population, right?
More like
narcolepsy, certainly. Yeah, in adolescence, there's a peak. I've seen it down to 4 or 5. I think the earliest case report was in a 1-year-old. I think that was actually at UNC. They reported that. It's very hard to pick up excessive sleepiness in a 1-year-old. Proved it with, I think, CSF testing of orexin, which is one way of diagnosing narcolepsy.
And you're talking about a child with narcolepsy. And of course, like sleep paralysis is very alarming. If your child tells you have sleep paralysis, definitely worth learning a little bit more about it, talking to your doctor. But to me, if they come in the office with this history, I'm like, are they sleepy or not? If they're sleepy,
Yes,
then we're looking at narcolepsy testing. If they're not, usually I'm reassuring them. And if it's happening quite a bit, you could consider something like a course of an SSRI. I've never had to do that myself.
So I have a question for you guys. Narcolepsy, you're talking about narcolepsy. And what triggers so I'm thinking of pediatric cases, what would trigger someone what would the child be presenting with to even start the process of considering the fact that it could be narcolepsy?
I'll tell you the typical path for me, which is it's usually disabling sleepiness. It's socially impairing level of sleepiness that comes on in kind of a subacute over the course of weeks to months. And it's usually school issues that kind of raise the red flag, which like they keep falling asleep in school and teachers can't keep them awake. That's usually the presenting factor with me, unless they also have cataplexy, which does occur in a certain portion of children that have narcolepsy, in which they have sudden intrusion of that REM muscle atonia. It can lead to partial paralysis or actually full body paralysis very quickly and seek evaluation. But it's just the disabling sleepiness. And they usually already seen an endocrinologist, and they've seen an infectious disease doctor. By the time they're 10 years later, finally get plugged in with a sleep doctor. The median time to diagnose from the time of symptom onset for children is like 10 years. It's really terrible how much time is lost for these children.
our sleep medicine fellows, they mostly come from the adult side. You know, they're mostly internal medicine doctors because sleep medicine is a pediatric and adult specialty. And I heard a lot of MSLTs because, again, not in every child is sleepy. If they have snoring or some other thing that looks like maybe it's just sleep apnea, but I just feel like it's a real missed opportunity. You don't want that kid to come back in 5 years and you saw them and you missed narcolepsy because it really can change the trajectory of their lives if you diagnose them early or not.
Yes.
Did you say
Truly.
SMLTs?
Multiple sleep latency test.
Thank
So
you.
you do an overnight test to make sure they get enough sleep. And there's nothing like sleep apnea fragmenting their sleep. And then you offer them 5 nap opportunities the next day and you measure how quickly they fall asleep. But yeah, I think in general, parents' insomnias are common. And I don't want to seem really alarmist to parents who are listening, but I think one of the red flags in general is if your child is having interrupted sleep at night, and it's very frequent, or they're sleepy during the day, I think those are absolute signs that it is worth pursuing. We can talk about these different phenomenon and what are the red flags in different situations, but I'd say that regardless of the type of thing that's happening during the night, those are the sort of things that get my attention. Snoring, frequent events, daytime sleepiness, or difficulty in school in general.
Yeah, no, I like all of those. I'm always focused on the safety portion as well. And so I've had situations where the child is currently getting into situations that can be unsafe. Older children that can manage to get outside of the house, for example. I had a child that had a 2-level house and would always manage to open the window and actually, on a few occasions, climbed out on the roof during a sleepwalking episode. And so I'm always thinking, what are the safety implications of what they're doing? And then we're always thinking about, is it truly a parasomnia? Because weird things happen in sleep. And so we're always ruling out some of the mimickers as well. And we know there can certainly be just behavioral issues, right? Is it truly a parasomnia versus is it more of just a behavioral arousal or awakening? And then in my mind, I'm always thinking as the neurologist, I'm like, I can't miss nocturnal epilepsy, which can present in really unusual ways. And so I'm also keeping that on the list. But I agree, if something's happening repetitively at nighttime and the child is having any sort of daytime manifestation, or you feel like their safety is at risk, certainly bring it up, at least to your pediatrician, and talk about it.
So from my perspective, all of that is so helpful. What I see a lot is parents in mom groups or whatever on Facebook, Instagram saying, I don't know what to do. My 10-month-old is waking at night and really upset, and I have to go in there, and it's happening every night. And the response is almost always night terrors. Like people are like all about it being night terrors, and doesn't matter how young. Sometimes they say 6-month-old. And my understanding is that it's rare. It's very rare for a baby or young toddler to be having that kind of parasomnia. I know nightmares can happen earlier, bad dreams, but when do night terrors really start to become more common, I would say? And then what is the prevalence of night terrors?
Great questions. I'll tell you what, of all the parasomnias, and Craig, feel free to jump in here, but the confused arousal, sleepwalking, night terrors tends to be the least frequent. I'd say somewhere probably around 3 to 5%. I usually think of parasomnias at the earliest, typically like 3 and above. In infants, it's not going to be a night terror. It's going to be usually just a behavioral awakening of some type. But that's my take. Craig?
And just to, I think, for defining things for people, confusional arousals are where a child doesn't leave the bed. They may sit up, they may talk. They usually don't seem lucid, but it seems pretty benign. Like you might notice it if you're on vacation with your child and you're in the same room as them, but unless you have a monitor, you might not notice this at all. A night terror is when your kid is screaming. They don't leave the bed, but they have this fight or flight response where they may be sweating, they're screaming, and you cannot console them. The first time this happens, it is very scary to parents because imagine being woken up by someone in your household screaming. It's not a good feeling. And I remember my older son used to have a night terror every time we went to stay at our in-laws.
Yeah, it's just an excuse, Craig, to not go to the in-laws.
So we don't need to go to the in-laws anymore.
My in-laws were lovely, but my mother-in-law had terrible insomnia. And my father-in-law, who's not going to listen to this, would just sleep on the couch all night with the TV blaring. But he would just be screaming. My mother-in-law would run and she's, "What's wrong? What's wrong?" And I'm like, "God, it's okay."
Mhm.
But it is, once you've experienced it, it goes more from being something that's really scary to something that is a nuisance. If it's happening quite frequently enough that it's on your mind, definitely talk with your pediatrician, because any of the disorders of sleep fragmentation we think about, things like sleep apnea or medical conditions, can trigger these events in people that are predisposed to them. Not every child is going to have sleepwalk or have a night terror, but if you're prone to that, I think there've been studies, if you take a kid that's sleepwalking, you set them up at night, they'll just get up and just motor out of their bed. So any underlying problem, say if they have asthma that's poorly controlled, and they're coughing, eczema, they're itching, it's going to make them more likely to have these events. And that's why it's so important for people to work with their pediatrician.
Now, can fevers be a cause of that, or is it just illness in general? Because the only time my daughter has ever had, she's only had two, and they were awful. And I'm sitting right next to her, and she's screaming for me, like reaching across the room, yelling, "Mama," and it's like heartbreaking. But she had a fever both times, and maybe that's just one of those triggering events that can cause. Some people talk about emptying the bladder before bed. Can having to go to the bathroom cause night terrors?
I'll tell you, in my experience, it's a more rare provoking factor. But just like Craig said, at the end of the day, when I'm taking it step by step in clinic, I'm like, first and foremost, are they getting adequate length of sleep? Because we know sleep deprivation will definitely predispose you to having it because you spend more time in deeper stages of sleep, out of which night terrors tend to occur. Number two, are there those internal disruptors, medical issues, reflux, ear issues, eczema, etc., sleep apnea? Are there external disruptors? Is the TV blaring in the house? Is it a busy street corner? Has the family brought the child into their bed because it's happened one time and now it's happening every night? That's causing the child to have multiple arousals and poor sleep. And so any of these things could potentially predispose you. But yes, fever, illness, for sure. Weird things happen in sleep when you have a fever. Absolutely.
Is there anything you as doctors can do for that? Because my understanding is that you just grow out of them, but I don't know if that's factual or medically factual.
Yeah, no, Craig, I'll take your lead here about how much medical stuff you want to share, because I don't want people using techniques willy-nilly, but
Yeah.
I have to go
sure.
over some of the basics of.
I think that if anybody's going to listen to the podcast, there are pediatricians and sleep consultants that listen as well. I like to have more detail instead of less.
So I will tell you that after I've assessed the sleep duration part of this, to say, hey, listen, we got to make sure your schedule is adequate. If I can't find any internal disruptors or external disruptors to sleep, let's say this is a teenager who out of the blue started having like night. It's not a typical pattern. It didn't start when they were young. There's oftentimes a family history that we think there's likely a genetic predisposition to having parasomnias. So if things are occurring out of the blue and the child is like snoring, for example, I'm like, that's a little bit unusual. Let's consider doing a sleep study to make sure I'm not missing any other disruptor of sleep. But in the absence of any disruptor that I can find, oftentimes what I'll consider doing is scheduled awakenings. Scheduled awakenings has data to support it. What you do in this is you go in there about 20, 30 minutes prior to the time of their typical event, and you wake them up. And the advice I like to give is wake them up enough that they can say their name and then let them go back to sleep. Just so you know that they're relatively fully awake. And then let them be for the rest of the night. If you do this for 2 or 3 weeks straight, in the majority of children, for some reason, it gets a reset switch in their brain, and these episodes go away. This includes night terrors. It includes sleepwalking. Again, as Craig mentioned, confusion. There is probably a role. There's some data to also support melatonin. And again, this is something you got to talk to your pediatrician about. But there is a role, I think, for melatonin. Whether it actually gets to the pathophysiology and the underlying mechanisms by which this happens, or is it just increasing total sleep duration? Who knows? But there is some data there.
And then I hear people who say that those things increase with the use of melatonin, or he got night terrors from them.
Yeah. I'm always curious distinguishing nightmares from night terrors. Melatonin can certainly cause nightmares. And if in my world, if family links a particular side effect, the initiation of a medication or a supplement, then we just stop it and see if it resolves. And if it does, and I still think it's beneficial, we reintroduce and see if the symptoms come back just to make sure it actually is causative. Yeah. There are some stronger, more potent medications that I've probably prescribed like less than 5 times in my 10 plus year career that can also help, but it helps by decreasing deep non-REM sleep, which is not something that I like to do for children. You know,
No.
we like to keep them in deep non-REM sleep. Yeah.
And actually, there's just two things I want to double click on that Sujay said. The first step in looking at these is actually making sure the child's getting adequate sleep, because insufficient sleep is a very clear trigger of non-REM parasomnia. And it's very common. And we see it sometimes in adolescents where they had a sleepwalking when they were a kid. It went away, then they hit adolescence, and all of a sudden they're staying up super late. School starts too early, or they go to college and they have these crazy schedules. And I think that is really important for parents to know too. And sometimes you'll see if your kid's up super late one night, you're out on vacation, it's a holiday, they're going to have a parasomnia that night because they've been shortchanged on sleep a little bit. But I think just to talk a little bit more about sleepwalking, where safety isn't an issue, for kids that are frequent sleepwalkers, you do need to be really careful, especially if you're staying in a location that's different from home. When I'm thinking of people who are staying in hotels where there's a balcony or unfamiliar locations, I have kids that are sleepwalk intermittently, and some kids are agitated when they sleepwalk. They might even be violent. Others are just calm, but they still get into mischief. I agree with Sujay. I tend not to write meds for these kids unless I've had a few where they're nightly events, especially when kids going to college, or they've eloped from the home, they've gotten injured, other people have gotten injured. Think about it.
Yeah. Another example is I had a child who lived in a trailer home, had 8 other people in the trailer home, would sleepwalk every night and wake everybody up. And it was leading to complete dysfunction and disarray. And that's the situation. I said, okay, that probably merits. Another thing I'd love to emphasize is that we've talked about night terrors versus nightmares, and oftentimes there's a confusion there. You know, nightmares is vivid dream imagery. Your child is fully awake and telling you, I'm scared because I just saw a monster in my dream. Whereas night terrors, they're not aware typically that you're even there. And oftentimes if you are there, even if they're calling for you, they're like pushing you away and completely frightened. As Craig mentioned, they have that sympathetic activation. They're terrified. They look terrified. And they usually do not remember it the next day. If they do remember, it's usually after the night terror is complete and they woke up from the night terror, and then they might remember that. But they typically don't remember the event itself. And parents oftentimes go to what just happened during the day? What trauma did they experience to start beginning to have night terrors? And the answer is they didn't. We don't think it's actually due to any underlying trauma or psychological distress, even though it looks very distressing, like they're truly in distress. I think that's also important just to provide some reassurance to families that it's likely not due to some sort of daytime trauma they experienced.
So let's segue to nightmares then, because nightmares are incredibly common. I don't think there's anybody that hasn't had a nightmare. I don't think we know when kids start having nightmares because infants can't tell us, right? We've all had our kids cry in our sleep. I can definitely remember when my kids were babies, they wouldn't be screaming their heads off for me, but they had this sort of piteous crying. I'm like, I don't know, maybe they had a bad dream. It's hard to say, right?
Yeah.
But as Sujay said, they tend to happen in the second half of the night, and they have a clear narrative to them. They have a story. And if someone wakes up from a nightmare or a dream, for that matter, they're lucid. Whereas if you try to wake someone out of a non-REM parasomnia, they're coming out of non-REM sleep, they're often pretty out of it.
And my question about that, is it in the best interest of everybody to not wake or attempt to wake someone who is sleepwalking or having a night terror?
Yeah, people always used to say, do not wake up someone that's sleepwalking thinking that it's going to hurt them. But what happens is if you wake somebody up, they might become scared and agitated and frightened and lash out, etc. And so the usual approach is gently guide them back to the bed if you can, without alarming them or being too stimulating.
Yeah.
Yes, arousing them out of the event will stop the event, but perhaps the detriment of kind of everybody's well-being, because they'll be shocked and surprised and maybe angry.
The first thing I was taught in sleep doctor school is that if you do die in your dream, you do die for real.
Oh,
They tell us that from the beginning.
Yeah.
Just so we know. I've been on alert ever since.
Yeah.
gosh.
I've been mainlining REM suppressive drugs since that day.
Don't do that. You don't die. Although I will tell you that if you feel like you're having dreams of like drowning or suffocation or you can't breathe, you may have sleep apnea. Anecdotally, I'll tell you, some people do experience this sensation of like, I'm being suffocated recurrently, and you wake up gasping. It's like, you may have sleep apnea. So you may want to look into that.
What's interesting, nightmares in my world are very seldom the reason someone comes to sleep clinic. And I think because it is such a common shared experience that people generally are fairly comfortable with it. That being said, there are certain things to be aware of that, especially for practitioners, that people who've experienced trauma often do have issues with severe nightmares. My colleagues who work at the VA with veterans deal with this all the time. Unfortunately, there are many children that have experienced trauma as well. And I would say to parents, if your kid's having a nightmare, it doesn't mean that they've experienced some hidden trauma. The parents almost always know about the trauma. It's more important for providers to recognize that if someone's coming in, they're endorsing a lot of nightmares, they have insomnia, it seems disproportionate to what you would expect from what you're being told. Often, if you ask in a sensitive way, you can uncover with the family a little bit of a trauma history. I feel like this is something we just see sometimes. Kids with very severe sleep disruption and nightmares, they're dealing with something. And dealing with trauma is something that you really need mental health providers to help you with. It's not something certainly that I feel comfortable dealing with. Not even every mental health provider deals with trauma. You really need experts.
Yes. Wholeheartedly agree. I think we're great at screening because we know the role that it plays when it comes to sleep, overall, when it comes to mental health, and even our patients, older patients that experience depression and anxiety and how that's affecting their sleep. So I think we're great at screening for it, but I agree. We really have to lean on our mental health colleagues to jump in and help for sure.
Now, I was going to say, we are coming up on 8 o'clock. I don't know if you guys want to push through and we could go through RLS and restless sleep disorder, or Sujay, if you got
Yeah,
off where your deal is.
Hey, I'm here.
we
you
could
know.
talk for hours.
Yeah. No, listen.
No, I'm happy to push through.
I
Happy to
think
chat
the
about those.
Yeah, Ariel, are you
restless
good?
leg is, yeah, I try to medically screen people so that I can, if something seems off, I just send them to the doctor. But I'm not quite sure what I would need to be looking for with regard to restless leg.
Sujay, why don't you just explain what restless leg syndrome is?
Restless leg syndrome, like all of our sleep disorders, we have a set number of diagnostic criteria, but it's essentially characterized by an abnormal sensation of either discomfort, pain, something that you feel like is uncomfortable, that is experienced predominantly in your legs, that worse or only present at nighttime. When you move your legs, it actually helps the symptoms. And when you're still, the symptoms tend to be worse. And it's not better explained by another underlying medical disorder like neuropathy, et cetera, and should cause some sort of kind of dysfunction when it comes to sleep loss, et cetera. So that's the typical definition of restless leg. It can start very early, and unfortunately, when we ask adults, a good proportion of them will say my symptoms began prior to when I was 20 years old, and a good chunk of those will also say it actually began before I was 10, but I couldn't adequately explain what was happening. Pediatricians have so many things to screen for. I'm not trying to throw pediatricians under the bus here, but oftentimes they're like, it's just growing pains and they'll be fine. And it's missed for many years. We do think it has something to do with dopamine regulation in the brain, perhaps a decrease in dopamine due to a circadian pattern of synthesis of dopamine in the brain, such that it tends to be lower at nighttime. And we think that iron plays a role as a cofactor in the creation of dopamine. That's why we're oftentimes screening for iron deficiency in hopes of making sure the patient has adequate amounts of dopamine. But a lot of children that have restless leg also have what we call periodic limb movements of sleep. And so this is kind of the sister diagnosis of restless leg. Restless leg is what you experience while you're awake. Oftentimes you have limb movements while you're asleep. Like 80% of patients that have RLS will also have periodic limb movements of sleep, and that can also disrupt the quality of your sleep. So yeah, that's a broad overview.
And periodic limb movements of sleep are something that get detected in an overnight sleep test.
Yes.
They can be subtle, but they're just leg kicks that happen in a series of 4 or more. Where Sujay and I sit in the pediatric clinic, because we have children that are often too young to really express this. And we also deal with children who are not always neurotypical and may not have, even if they're old enough, they don't have language to describe these things. So we almost have to infer it. I've had parents tell me that their kids will kick a lot. They'll try to press their feet into them. They may say that their feet are hot or cold at night. True story. I was studying for my sleep medicine boards the first go around, and I read a sentence and it said, kids with restless leg may say they have too much energy in their legs. And that's what I used to say to my folks when I was a kid if I had too much caffeine. And caffeine makes restless leg worse. And then I realized I've got a little bit of restless leg. It doesn't happen that often, but if I'm anxious or I've had too much caffeine, I get that feeling. And I feel like this is the art of pediatrics sometimes. And it makes our adult colleagues crazy when they come with us. And we're trying to guess what's going through a 2-year-old's mind from what parents are telling us. I think in the hierarchy of restless leg, the other thing is the criteria that Sujay mentioned often in younger kids, they don't necessarily fit those criteria perfectly. The symptoms may not be worse in the evening. Or, for example, I think there's probable and possible restless leg if there's a family history and a first degree relative that helps you with the diagnosis. The first line treatment in kids is checking a blood iron marker called a ferritin and treating. We usually treat for values less than 50. I don't know what you guys do.
Same. Yeah, we try to get them to 50. In some cases, 50 is the goal. It can be challenging to get a child to a level of 50.
What is ferritin for the layperson?
Yeah, it's essentially a measure of iron stores in the body. And the challenge with ferritin is if you're sick, it's what we call an acute phase reactant, and that it actually increases just in the setting of kind of inflammation in the body. And so you don't want to check it when you're sick. You want to check it when you're otherwise well. And the goal is, trying to get above 50. And again, all with the premise that we think it works as a cofactor in, I think, the tyrosine hydroxylase, which ends up making dopamine for your brain. The challenge is if you check a ferritin in any toddler, it's going to be below 50 in my experience. Okay. So I usually want to be fairly sure that before I put somebody on a full-fledged iron supplementation, which, by the way, can be dangerous because iron overload is a super dangerous phenomenon. But I want to be fairly certain that we're in the realm of probable restless leg. If we pick up periodic limb movements of sleep on a sleep study, that could also serve as kind of another surrogate marker that pushes us more towards likelihood of restless leg if they don't fill all the classic criteria. But there's something that I want to sink my teeth in to be like, okay, they have a sleep disruption due to a restless phenomenon that's affecting their sleep before I put them on iron. Sometimes I'll hedge my bet and say, let me put you on a multivitamin with iron, which isn't a full-fledged iron supplement, but it'll hopefully stabilize you where you are and not make your iron deficiency any worse. But it can be a challenging diagnosis to pin down.
And is iron the only course of action for treating?
There are other medications. It's funny, at the recent sleep conference, I wasn't able to attend, but the big brouhaha now is that for adults, we're no longer recommending dopamine agonists. So we used to recommend dopamine agonists for adults, and oftentimes they'd be used on the adult side very early, much earlier than I would ever feel comfortable with doing, even in adults. But medications like Mirapex were used really early. The typical, even for adults, I think the typical approach should be, what's your iron status? And if it's low, you got a supplement. The next line is typically medication in the realm of the gabapentin family. And so gabapentin and its sister pregabalin or Lyrica are the ones that we oftentimes go to, which can really help with the symptoms of restless leg. And now on the adult side, I think they're starting to use low-dose opioids instead of the dopa agonists. And I think most families would also be somewhat opposed unless it's a really kind of severe situation. But then a lot of it is also sleep hygiene, like avoiding the things that worsen it. So caffeine, antihistamines are notorious for just making restless leg symptoms much, much worse. And so sometimes we can help from just a avoidance standpoint of things that will make the symptoms worse.
Stretching, leg massage.
Cold plunging?
Cold plunging. So we'll get Huberman on here next.
Yeah, that'd be great. Everybody will be on magnesium glycinate.
Oh, I love that.
I thought
sleep.
I have the receipts from my Oura ring. I'm not today. But we definitely should talk about this. But I want to ask a little bit about gabapentin, actually, because I remember I had one parent who was in law enforcement. They moved up from the South. We talked about gabapentin for a child, and she said, I'm not going to give that because it's a drug of abuse. And I think that's a little bit of an exaggeration, but I remember going to the sleep meeting, and Suresh Kodagal, who's a very smart sleep doctor, who's written a lot about restless leg, said that has come up in his practice as well. And I think it's more of a concern in the South than it is in the Northeast. Has a parent ever said that to you?
Yes. And interestingly, when I Googled it, there was some article that was coming up very high on the Google search that said something about gabapentin being worse than opioids. And this was something that I think a lot of people latched onto. Any drug you're using in the right way, at the right doses, with access that you are actually monitoring, is not going to be a drug of abuse. Even our stimulants, when we're using them for narcolepsy in the right way, it's not going to end up turning into a drug of abuse. Gabapentin can help with neuropathic pain, and there are some indications for seizures, but we rarely use it for seizures. But no, when it comes to the kind of euphoric effect, for example, or the addictive effect of gabapentin, it's just not there.
Yeah, the doses, I think, clear there were mega doses of it, like 4 or 5 grams, and there was also taken with other drugs. So it's just, but just to reassure parents, first of all, your pediatrician wouldn't be prescribing this for you. I think that usually restless leg is something that your pediatrician is going to be familiar with sleep apnea. They're going to be familiar with sleepwalking. So I think if your child's complaining about their legs at night, I would just encourage to see if you could make an appointment with your friendly neighborhood sleep doctor and drill down on this a little bit further, because it's a nuanced conversation. Even things like supplementing iron aren't always straightforward. There are various preparations. Do you dose it every day? Do you dose it every other day? There's I like the Novoferrin preparations, but not everybody can afford them. Like, they're palatable.
Hey, Craig.
Ariel had a listener question.
Yeah, that's what I was wondering, if that was appropriate to ask or
Sure.
not. Okay. So we got a listener question in our email, Gmail, thesleepeditshow@gmail.com. Please send us your question. Anna L asked, my sleep-trained 3-year-old has restless leg syndrome, diagnosed by a sleep medicine doctor via sleep study, blood tests, and symptoms. However, we've gotten his ferritin levels above 50 and he still wakes multiple times a night. Melatonin makes it worse. His doctor said it will eventually improve with time as he gets older. He is well rested during the day, even with the awakenings, but we are not. Any other tips for parents and kids struggling with restless leg syndrome?
Craig, I'd love to hear
Struggling.
I'll tell you my approach, which is restless leg is difficult to diagnose in that young of a child. And every sleep practitioner is different. And the practice of sleep medicine is a lot of art, as Craig alluded to, and sometimes not so much science. So for me, a lot of times I'd want to diagnose them myself, see them in clinic. Like, do they truly have restless leg? Or do they just tend to be a restless sleeper that has another issue, or behavioral insomnia of childhood, or something else that's causing them to wake up frequently? I would certainly, as I do with all my patients, would still screen for being able to transition to sleep independently at the start of the night. Are they able to do that well? Constant assistant? Is the caregiver coming back in and getting them back to sleep relatively quickly? Is it truly a discomfort issue that's waking them up, or is it more of a habitual due to sleep onset associations? And so we're making everything else as perfect as possible. And if I'm still left with a child that is complaining that their legs truly bother them and has evidence of disrupted sleep, after doing all the sleep hygiene and the behavioral insomnia stuff really well, then yes, I am still going back to my core therapies to say, okay, if we've gotten iron up that high and we're running into side effects of constipation or lack of palatability and the child is refusing to take more, then I am exploring other options like gabapentin. But I cannot think of a single time where I've put a 3-year-old in gabapentin for restless leg, to be honest. I would be surprised if it was true, real deal restless leg at that age.
Yeah, I'd want to see a sleep test in this kid, and I'd want to see the movement index through the roof if I'm going to be saying this is the cause of these nighttime awakenings. Maybe it's been done, but certainly worth a sleep test hasn't occurred, worth doing, especially if the child's falling asleep independently. So let's close with talking about restless sleep disorder, which is a pretty new diagnosis for 2017 or 2018. And I thought it was very clever what they did with this, because I thought when they created this taxonomy, I'm like, oh, I see these patients all the time and I haven't known what to do with them.
What do they look like?
They described kids that are not having sensory phenomenon, so they don't have restless leg, but when they're in bed at night, they have these large full body movement. People may talk about them flopping like a fish or moving around like hands around a clock during the night. The sort of kids that nobody wants to share a bed with on vacation. And the key is that there's some daytime effects as well, like they're sleepy or they're having problems paying attention to school, etc. Would you say that I covered that?
Yeah, I think that's dead on. And I agree. It's this phenomenon that we've seen, and now they've put formal diagnostic criteria on this. And so we're like, okay, we could potentially diagnose you based on diagnostic criteria. It does involve actually getting a sleep study to confirm that they're having, I think, more than 5 movements per hour that are large and fit the bill. But it's still tough. For me, it still comes down to really iron seems to be the go-to, even for children that have restless body type of phenomenon. And then I really don't have a great sense still of chicken and egg. We have children that have baseline attention issues that tend to be on this ADHD type spectrum, that we know their brain engine idles at slightly higher level, right? Like we're working on, they got to get down to here, whereas most of us has got to go from here to fall asleep, and they're always idling here. I don't know if that neurochemistry milieu makes you more likely to experience these types of phenomenon. I do think there's still a lot of debate regarding what actually causes this phenomenon. But it still comes down to, I think, the basics. I think some of the studies, they look fairly robust. They look at a large number of kids, typically 6 to 18 years of age. And so it seems like, yes, there is probably something going on. But to me, I would always be hesitant because a lot of families bring in, for example, monitor data. They say, oh, my sleep monitor picked up this many movements at nighttime. And one thing that I'm always harping on is, of course, how does your child look during the day? Are they doing okay? Because there are a lot of kids that move around a lot, particularly really young children. Toddlers, early school age children are notorious for just being active sleepers, but yet their brain is still getting the sleep that they need. And so one thing I'm always asking them is, okay, first, how does your child look for sure? And then number two, if you are experiencing this, is it occurring in a format such that they have a lot of restlessness and then they go the next hour and you know they're going to be fine? And then they have another spurt of restlessness. If it is a perpetual, constant motion to the point where you're like, how are they getting good quality sleep? Because they're always moving. Every few minutes, they're moving. That's when the yellow flag goes up. And I'm like, could this potentially be something that's truly disrupting sleep quality?
Yeah, no, I think that's true. And it is always so tricky because often these things come to light when, again, not to imply that everybody's kids have their own, like many of our families, they're sharing rooms, they may even be sharing beds. Other parents, all of a sudden they go on vacation with their kids, they share a bed for 2 nights and it's a catastrophe, right? They're like, oh my God,
Yeah.
he's snoring, he's moving, etc. And I think it is very important to look at the child's functioning during the day. That's a really good barometer of how things are going. And I agree with you. I feel like in the Venn diagram of whatever restless sleep disorder is and ADHD, there's probably a large amount of overlap there. And that being said, if their ferritin's pretty low, give them a trial of it and they're doing better and that correlates with in the ferritin going up. I think that's useful. And sometimes, I don't know, in our lab, I feel like we've had a trouble getting agreement about what scoring these large body movements. Do you guys actually index these in your lab?
We don't index them. And I'll tell you that it's very rare that I have ordered a sleep study. If I have a child that's really restless and it's affecting daytime function and I have nowhere else to turn, I'm usually still going down the ferritin route. I'm saying because there are a lot of movement issues. So I think we've gone down that route anyway. So it's rare that a sleep study is particularly looking for this to make this the diagnosis. Let's look at iron, see what happens.
And at the end of the day, even with all the difficulty of getting a good ferritin value, dosing iron, finding a palatable format, it's still, I think everybody's a little bit more comfortable with it, providers and parents, than like prescription sleep medication, right?
Yes. Yes.
It just feels like a lower tier intervention.
Absolutely.
So listen, guys, I think we covered what we set out to cover. This has been amazing.
Absolutely.
Now,
I've definitely learned.
Sujay, you've got a pretty big footprint online. I've got your professional profile, your Instagram, your TikTok, your links. Is there anything else you want us to share online here?
No. And just, the one thing I do like to share on all podcasts that are like parent facing is I always like to say that everyone is looking for that perfect magical solution for everything when it comes to like potty training, when it comes to feeding, when it comes to extracurricular activities and sleep. There are like a million right ways to raise a thriving, happy child. And let's rule out sleep disorders. But when it comes to even the behavioral approaches to sleep, there are a million right ways to do it. So I tell families, there's no one right way. Take some of the pressure off. If your child is happy and they're thriving, you're doing it, right? Every parent struggles. Everybody has opinions. I get it. Let's be kind to other parents. I don't know why parenting has turned into a blood sport online and like these threads. Just be kind to one another. Go a long way if we're just kinder. And if you feel cranky all the time, consider getting more sleep.
Yeah.
Absolutely.
I'll put a pin in it. I'm Craig.
I'm Arielle Greenleaf.
So this has been the Sleep Edit. And if you please trying to get this started, please share online. Arielle, what's our email inbox again?
The sleepeditshow@gmail.com.
Tell your friends. Okay. Thanks a lot, guys.